Thank you, Emmett, and welcome everyone. I'm Dan Pollock. I'm the Surveillance Branch Chief in CDC's Division of Healthcare Quality Promotion. Just a brief overview of the agenda. I'll kick things off with some updates. We'll talk about the APIC 2021 conference available for meeting with NHSN virtually. We'll discuss the COVID module updates for long-term care and for dialysis. And then we'll also talk about upcoming releases, patient safety component, neonatal component, a new component, patient that are forthcoming. We'll discuss some transitions in CDA HAI vocabulary provisioning, where we're moving to an NLM resource called the Value Set Authority Center, or VSAC. We'll do some antimicrobial use and resistance updates, as well as some updates about additional vendor services, and then finish up with some miscellany and then opportunities for Q&A. So the next slide is the general NHSN updates. So we're continuing with one major release a year, and the changes in each of the releases will reflect protocol revisions, transitions to new CDA versions, and the effective date for these major releases will remain close to as possible January 1st of each year. We also will continue with non-major releases that may include a new component during the year, minor changes, defect resolutions, and infrastructure maintenance and support. And then COVID updates are going to occur on an as-needed basis, particularly as the pandemic moves into various different phases. Next slide, please. So our NHSN release 10.0 is scheduled for August 2021. This is one of those mid-year releases, and it will include, we're very excited, the new neonatal component. We had to move it from the original summer date because of so much COVID activity. Release 10.1 is scheduled for December of 2021. That will include the defects that will be covered with fixes and the change requests that will be effective January 1st on 2022. And the next slide is, again, with respect to APIC, we're going to offer teleconference meetings. If you or your organization want to schedule a meeting, please send an email to our CDA mailbox, the address on the screen, nhsncda@cdc.gov. And with that, Amit, I think I turn it back over to you.
Yes, thank you so much. All right, so let's start with some information around our COVID module. Currently, the active components for the COVID module are for long-term care facilities and dialysis. If you are not familiar with the COVID module, please visit the NHSN website. Here on the screenshot, it shows the link to both components on the main NHSN webpage. Each module has previously recorded webinars and training information. You can also find guidance on the different pathways, the table of instructions, and required fields that are collected, and also CSV templates and other documents to help you get started. Next slide. For long-term care facilities, the following pathways are being reported for: resident impact and facility capacity, staff and personnel impact, supplies and PPE, ventilator, therapeutics, vaccinations, and POC testing, or also known as point of care testing. Next slide. As promised, direct submissions is now available for point of care testing only. The accepted file formats are either CSV or the HL7 2.5.1. A guidance document for how to sign up your long-term care facility to use direct can be found under the importing data link in the CDA submission portal. As a reminder to those who might be new to direct, this is not a requirement. It is simply another method to import your POC test results into NHSN. The template for the CSV file can be found on the LTC webpage. Next slide. The dialysis COVID module accepts the following pathways: patient impact, staff impact, supply and PPE, and vaccination testing. Next slide. Again, if you would like to learn more or have questions after visiting the website, please send an email to the main NHSN help desk. As Dan had mentioned earlier, we are currently doing about monthly updates for this module as needed. So any new changes or updates that are happening are being done on a monthly basis. We do try to send out notification emails when possible to notify users of when the new updates are taking place. Next slide. Right, next, I'll review one CDA update in the upcoming 9.5.4 release in patient safety component. Defect 9637 corrected a CDA-only clip error. CDA is allowing import for the question if there was a contraindication to chlorhexidine, indicate the type of contraindication. The answer to this, if it's selected yes, or if the patient is older than 4 months, the user should not be allowed to select facility restrictions or safety concerns for CHG use in premature infants precludes its use. On the user interface, this option is grayed out, so it cannot be selected. However, it's being imported via CDA, so we will have this corrected in our 9.5.4 release. Next slide. All right, next we'll cover the neonatal component. So as mentioned earlier, the neonatal component is scheduled to be released in 10.0, which again, we have planned for August 2021. Late onset sepsis and meningitis will be valid events for this component along with the denominator. As a reminder, this component will be CDA entry only. It will be using the R3D4 implementation guide, which has been shared in the 9.5 toolkit. Next slide. All right, and then I'll discuss one CDA update happening at the end of this year in our December release for 10.1. The following HAI events will have a new COVID question included, and this will be via CDA. So SSI, BSI, UTI, and VAE. The question will ask COVID-19 with an answer of yes or no. We removed the confirmed or suspected addition to this question. We found this to be burdensome and have removed it. This field is available on the user interface at this time and is optional, but will be required from January 1st, 2022. The CDAs which include this question will be updated to using the R4D1 implementation guide. This publication for the IG should be completed soon, and we will post it to our 10.1 toolkit on the website. The toolkit is not available at this time, but we do plan on adding it soon. All right, and I think with that, I will turn it over to Sheila Abner with updates regarding vocabulary.
Thanks, Ahmed. Next slide, please. So yes, I'm Sheila Abner, and I'm the terminologist for NHSN. So I'm responsible for maintaining value sets. And today we're going to focus on our migration to VSAC that Dan already mentioned. I've created several slides to review and that you can have as a resource later, but we'll spend most of our time with a demo of VSAC. And so starting with R4D1 implementation guide, you will no longer use the HAI_VOC Excel spreadsheet for distribution of value sets that's embedded within the CDA toolkits on our website. Instead, you will begin to use VSAC as the source of truth, and to access these value sets, you need to create a UMLS account, and we'll get to that a little bit later in the demo. Next slide. So this is just an overview of the published value sets in VSAC on this search value sets tab. If you were to filter on the steward to CDC NHSN, you will see a total of 107 value sets. And we'll go over how to download all of them, export, and the API resource in the demo. Next slide. So this slide focuses on highlights that we now have a second pathogen code value set for the antibiotic resistance option in addition to the major NHSN pathogen code value set, and that it's important to pay attention to the version of those two value sets, the version of the SNOMED code system that will correspond to specific IDM versions. Next slide. So when we get into VSAC, I will point out how the default is what's called the latest expansion version, and that's based on the most recent code system version that is currently in VSAC, which happens to be 2021 March US edition. And when you look at that latest expansion, it's going to show 2,468 concepts, but it's important for both of those pathogen value sets that you refer to specific, what's called steward expansion versions. And so when we look on the next slide at this 2021-0326 version, you'll see that instead of the, what was it, 2468 codes, it now has 5 additional codes, but it's not as simple as it's just 5 codes added. They could have subtracted 20 and added back 25, something like that. So up at the top, you'll see, specific expansion version selected, and you'll notice that it's pointing to a past version of SNOMED CT, in this case, 2019 September. And then when we look at, this is pointing to the metadata tab within VSAC. When you look at the description tab, we intend to use this note field to identify the specific IDM version associated with pathogen codes. So next slide, please. And this is intended to address some past confusion regarding when does a vendor refer to the IDM as a source of truth for vocabulary concepts versus what was HAI_VOC, and going forward it will be VSAC, and the source of truth is VSAC. But what this slide serves to do is show you the relationship between the IDM and what is in VSAC now. And so and this is for the ARO pathogen subset. If you were to filter on column S, ARO pathogen, and I can't see it on my screen, but at the end of that arrow, you see, I believe, 121 rows or records. So 121 in the IDM versus 97 that are showing up in VSAC. So there is a difference of 24. And so on the next slide, to understand the source of that discrepancy, if you were to also, in addition to ARO pathogen, filter on term type and only leave the P for preferred terms, that arrow is now pointing to 97, which matches what is in VSAC. And let's see. So, and the reason for that is VSAC only displays it's really called fully specified name, but it's the same as a preferred term. VSAC does not display synonyms. Next slide. And so this is just to reiterate the same thing, because this is leading up to a request for feedback from all vendors. When we look at the IDM pathogen codes tab for 2021, if you filter on term type and you filter out the synonyms and the inactive terms, you're left with 2,473 preferred terms, which matches what is in VSAC. And next slide. And so this is where I introduce your homework assignment. I'm hoping that people will take time to study this slide and provide guidance on whether or not it's okay to discontinue maintaining essentially all synonyms in the IDM, and that we only maintain the preferred term going forward. So like here's an image of the IDM for this concept, Burkholderia gladioli. Here you can see all of the terms associated with that concept through the SNOMED browser. In VSAC, it only lists the fully specified term, which corresponds to this. We currently have for this path organism a preferred term and 5 synonyms. Most of these are obsolete names that are just retained in SNOMED for historical purposes. But we really need to make a decision on whether or not we're going to continue maintaining synonyms. So please provide feedback to help us finalize that decision. Next slide. And so at this point, we're going to switch to the VSAC demos just so I can give you a basic orientation to the functionality that's available. And so share my screen. So are you seeing Value Set Authority Center?
Yes, we can see.
Okay, thanks. So I'll back up here on the Welcome tab. At some point, NHSN hopes to have a big white box here too, where you can simplify the download for all of the value sets, but it's going to take some time to work through that. So this is the tab Search Value Sets, where you have access to all published value sets in VSAC. You can see there are more than 10,000 value sets. And so if you do this steward drop-down menu, scroll through and select CDC, NHSN, and then hit search. So then we have filtered out 107 NHSN value sets. And so for each of these, and right now it's only displaying 20. I'm going to go ahead and go to 120 so we can see them all and just show you basic functionality. You can sort on name of the value sets, code systems. And so here we have a lot of content from CDC NHSN, which is a code system we're the steward of and maintain. Scroll down through here, CDC NHSN. We have some what are called grouping value sets, where we have content from 2 or more different code systems. So like right here, CDC plus LOINC, or I'm sorry, CDC NHSN plus LOINC, or CDC NHSN plus SNOMED. Most, essentially all value sets are extensional, meaning that we hand pick the content from the code system that makes up the value set. Then we're the steward for almost all value sets. There might be one where NCHS is the steward. We have the OIDs, and then here you can see the code count or the concept count in all of the value sets. So with that, what I wanted to do is point out these the retrieve option. So like if you were to select that box, you've selected all value sets. If you select that download button, what you end up getting is you get a zip file that has the 107 individual value sets in spreadsheets, but they're named by the OID. I'm not sure how useful that is. And then if you, let's get out of there, if you were to select this button, export search results, let me back up. When you select the download button here, you have like 3 formats that you can export the content: Excel, text file, or XML. If you were to click the export search result button, you end up with a single value set that has just the metadata for all of the value sets, the value set name, code system, type, Stewart, Boyd, number of codes. And then there's a third option of using an API resource that we haven't fully worked out the functionality yet. There's this Fire RESTful API. It may be that we use this VSAC SDS for sharing value set. And you can see here, there's a way to retrieve a single value set or retrieve multiple value sets, which is what I think vendors will want to do. And to access this, you're going to need to jump through a few additional hoops to get an API key. And it may be that we need to provide a script where we have all of the URLs to retrieve all of the value sets. And so the next thing I wanted to show you, if we want to focus in on, I have my, bear with me, NHSN. Here we go. My favorite value set, NHSN pathogen code. Click on that void. And if you notice now, it defaults to this expansion version of latest. If you know, when I said a minute ago, we may need to prepare a script to have all of the URLs. Right now it's pointing to latest, but for this pathogen code value set, as well as the ARO subset, it's going to be important to select a specific Stewart expansion version that we're going to provide you. So right now, when it's at latest, it's showing you the current 2021-03 SNOMED. Says latest up there. If you select a specific expansion version, it goes back to a past version, 2019-09, and also that's in the URL, that specific version. So I think maybe that's about all I wanted to show for the introduction. Real quick, I'm going to sign out and see if I can show you what you would need to do to, okay, so if you do not have a UMLS license or account, you push this button to request one. And so you have a few hurdles to jump through. So we'll have more information about the API retrieval, but for now, that's all I have.
Thanks, Sheila. All right, we'll get back to the presentation here. Okay, can someone quickly just confirm we can see the slides again?
Yes.
Perfect, thank you. All right, so hi all, I'm Amy Webb. I am an analyst on the AUR module team, and I'm going to kick off this next section of slides focused on the AUR module. First up, I'm going to mention a few data quality outreach activities and associated clarifications that needed to be made as a result. So we are currently conducting facility outreach for missing AR option priority pathogen susceptibility results. Our team is currently developing brand new national benchmarks for the AR option, including standardized infection ratios, or SIRs, as well as standardized resistant infection ratios, or SRIRs. We plan to create these benchmarks for the 7 priority phenotypes listed on the slide using 2019 data as our baseline. As a result of that work, we reviewed all 2019 AR option data for missing susceptibility results, specifically if the facilities reported not tested for drugs that would normally be tested according to routine clinical practice. We found 316 facilities that had more than 10% of susceptibility results missing for 1 or more priority phenotypes. Our plan is to exclude facilities missing more than 10% of susceptibility results from the benchmarking. Therefore, we wanted to reach out to facilities to ask them if they could, 1, update their 2019 AR event data with the complete set of results. 2, let us know if they could not send updated data due to competing priorities or unavailability of these data, for example, due to data suppression practices. Or 3, confirm that the data were correct as they were reported. Our original due date was April 30th, but we've extended to May 31st to allow facilities and systems time to review and update data as needed. As part of that outreach, we learned there was confusion about what actually qualifies as a reportable AR event. This slide highlights the 3 high-level criteria. However, the point to focus on today is actually number 3. Antimicrobial susceptibility testing must be completed. Further, the event qualifies for submission regardless of the susceptibility results. So, for example, if the isolate would still be reportable even if the isolate was susceptible to all the drugs tested. The isolate must be tested for susceptibility to at least 1 drug. If no susceptibility testing was performed, then it does not meet the criteria for an AR event and should not be reported to the AR option. So an example of that would be if the lab suspects contamination of the specimen and they do not perform susceptibility testing, then that isolate does not meet the AR event criteria and should not be reported to the AR option. The important caveat to this requirement is that the tested drug can either be an NHSN required drug, aka one listed in the protocol, or a non-NHSN required drug. So for example, if a Staph aureus isolate was tested for the non-NHSN required drug telithromycin, but none of the other 26 NHSN required drugs for this panel, it would still be eligible for AR option reporting. So this is why we cannot automatically reject AR events submitted to NHSN with all the drugs appearing as not tested. Separately, we completed outreach late last year and early this year on discrepancies between the reported admissions values within the MDRO CDI module, AU option, and AR option. With this outreach, we learned that we needed to clarify our definition of admissions being used in the AUR module. The definition itself remains unchanged. Admissions are still defined as the aggregate number of patients admitted to an inpatient location within the facility starting on the first day of the calendar month through the last day of the calendar month. However, we've added additional clarifying points. Specifically, a patient is counted as an admission when they arrive in an inpatient designated and when they arrive in an NHSN designated inpatient location, regardless of the patient status. For example, if a facility doesn't have a designated observation unit, but instead those observation patients are housed in an inpatient unit, like the medical ward, any patient in the medical ward would be counted as an admission, even if they were in observation status for the duration of their hospital stay. Further, a patient is counted as an admission even if they are discharged that same calendar day. This could happen in the case of the patient leaving the hospital against medical advice, the patient being transferred to another facility, or perhaps the patient dying. We've added this statement to our AUR module protocol that the definition is different between the AUR module and the MDRO CDI module. Since the MDRO CDI module requires a patient to have the admission and discharge dates on separate calendar dates in order to be counted as an admission, which is contrary to the second sub-bullet point listed here on the slide. If you have questions about the criteria for AR events or admissions, please reach out to us at the NHSN CDA mailbox, and we're happy to discuss further. And next, I'll turn it over to my colleague, Wendy Wise, to review the AUR defects that have recently been resolved.
Thanks, Amy. So I'm going to cover 3 defects that were recently fixed, as Amy mentioned. So these are 3 AUR defects. They were fixed in the last couple of months. There was a defect causing admissions to be saved in NHSN as 0 in some instances. It was fixed February 4th with the 951 release. Specifically, when XSI type equals INT instead of XSI type equal to PQ was used in the CDA file, the CDA file successfully imported into the application, but the admissions information saved in the application as 0, despite the fact that a value greater than 0 was entered in the FactWide-In summary file. Number of admissions should save correctly regardless of XSI type. While no action is required on your part, if your facilities notice 0 admissions in your FactWide-In AU line list, then they should first try to resubmit the AU FactWide-In files to see if that resolves the issue. So I also want to point out an SDS-related defect that has now been resolved in NHSN. AU CDA files were being rejected if they did not include optional SDS vendor information fields. The error message shown here was generated, vendor OID and or the SDS validation ID does not match NHSN vendor registration information. Please have vendor contact NHSN CDA at cdc.gov to troubleshoot. This issue was resolved the week of February 8th. So related to this, NHSN requires the SDS validated vendor information be listed first in a specific section of the AU CDA files. When the vendor information is not listed first in this section of the file, the same error message about the mismatch OID and SDS validation ID is generated. If any of you are experiencing this error and need help troubleshooting, please contact us. The last defect that was recently fixed was related to manually deleting AR events. With the current AR data quality outreach we're doing and the clarification to the event criteria that Amy just discussed, some facilities have identified the need to delete AR events. The only way to delete AR events is to do so manually within the application. When some users were attempting to delete AR events with specimen collection dates in 2018, 2019, and early 2020, they were receiving the message, error deleting selected events, as shown in this screenshot. This defect was resolved in last week's 953 release. If you hear from any of your facilities still experiencing this issue, please have them contact us. I'm going to turn it back over to Amy.
Thanks, Wendy. I'm going to cover 2 defects that we plan to resolve in the upcoming 954 release, tentatively scheduled for late May. First, defect 9579 affects the NHSN generated Promoting Interoperability Program, also known as the Meaningful Use Program, report for 2020. The application was not recognizing 2020 AU and AR summary data that were imported after the December 19th NHSN release. As shown in this example screenshot, the report was displaying no in those columns despite the despite those data being successfully imported. We emailed the facilities the corrected 2020 annual reports in early February, but are still planning to resolve this defect so that the historical 2020 reports generated in the application will be correct. No action is required on your part. Defect 9676 involves the minimum number of drugs to be included in the 2020 AU CDA file. Prior to adding remdesivir in July of 2020, the minimum number of drugs to be included in the AU file was 85. In December 2020, when we updated the 2021 drugs, we also updated the minimum number of drugs for 2020 to be 86. However, that assumed that remdesivir was required for the entire calendar year of 2020, which it was not. Remdesivir is only required for July 2020 moving forward. This defect will move the minimum number of drugs to be included in the 2020 AU files back to 85. Next up, we'd like to share some upcoming AUR changes slated for the 10.0 release, currently scheduled for August of 2021. CR2143 will add the ability to report no events within the AR summary CDA file. Similar to the other report no events code, you'd only use that section of code in your CDA files when report no events equals yes. The manual checkbox to report no events in the app will remain, and facilities can continue to use that as well. A very important note, this feature will only be available when using the R4D1 IG for the AR summary files. Also affecting the AR summary CDA, CR2158 adds the ability to report outpatient summary data for the AR option. We will collect outpatient encounters for the 3 outpatient locations that could submit AR data: emergency department, pediatric emergency department, and 24-hour observation area. As a reminder, an encounter is defined as a patient visit to an outpatient location. It is not a once daily count like patient days. We will be updating the AUR module protocol and our FAQs with the definition as we get a little closer to August. Similar to the previous CR, this feature is only available when using the R4D1 IG. In summary, the R4D1 IG will be required to report no AR events within the CDA summary file and report outpatient encounter data for those 3 select locations. However, since this change is happening in the middle of a calendar year, we'll be doing a soft roll-on, meaning that after the 10.0 release for calendar year 2021 AR summary data, NHSN will accept AR summaries using either the current R1 or the new R4D1 formats. Beginning with AR summaries for January 2022, NHSN will only accept files that use the R4D1 format. One thing I wanted to stress is that NHSN will begin generating missing AR summary alerts for outpatient locations beginning with the 10.0 release. This means that if facilities have these outpatient locations in their monthly reporting plan with the AR option box checked, they'll receive an alert on their NHSN home screen that the associated AR summary record for the outpatient location has not yet been submitted. The only way to clear the alert is to submit the summary record that includes the outpatient encounters. There is no way to manually enter those denominators. So if you choose to not use the R4D1 IG until 2022, we encourage you to allow for retrospective submission of 2021 outpatient AR summary data to allow those facilities to clear their missing data alerts. The last change I want to cover for 10.0 today is CR2804. We already have the ability to track successful submissions of AU CDA files by vendor, thanks to the AU SDS validation process. This CR will add to that and begin tracking the number of failed AU CDA submissions by month and vendor. Vendors can use the successful and failed AU submission metrics to support the real-world testing requirements outlined in the 21st Century Cures Act. The metrics will not be published anywhere and will only be available upon request, email request to the CDA help desk. We will then provide you with your vendor-specific metrics only. Now I'll turn it over to my colleague, Melissa Mojica, to share the 10.1 AUR updates. Melissa?
Hello, I'm Melissa Mojica, and I'll be discussing the upcoming change requests for the 10.1 release scheduled for December. Next slide. Change request 2835 will be an update to the AU option drugs for the 2022, which includes updating all NHSN local codes and outdated RxNorm codes with RxNorm codes as needed. This means that any drugs that used an NHSN local code will be updated to use the RxNorm code. Using the example shown on the slide, the NHSN local code of 1820-0 for ceftazidime avibactam will be updated to the RxNorm code of 1603839. You'll see these changes in the Antimicrobial Ingredients 2022 tab of the 10.1 IDM when it's shared later this year. Please note, at this time, no new drugs will be added and no drugs will be removed from the current list for AU 2022 reporting. Next slide. Change request 2422 is an AR event-related update and will be adding a new question to assess whether a patient was admitted during the hospital encounter. This will be conditional for specimens collected in outpatient locations for emergency department, pediatric emergency department, and the 24-hour observation location. Please see the screenshot of the snippet of code used to report this in the CDA file. This change request will require moving the CDA format to R3 normative IG beginning in January 2022. Next slide. Additional updates included in the R3 IG will include moving from RxNorm to LOINC for reporting the specific drug test results. We've illustrated these changes in the screenshot on this slide showing a side-by-side view of the R3 and R1 AR event samples. You can see the change from RxNorm on the right R1 sample to use of the LOINC on the left R3 AR event. Similarly, the testing method for each of the individual tests, in other words, the E test, MIC, and KB test, will use a more specific LOINC code as shown in the comparison. AR event sample files using the R3 normative IG will be shared when they are available in the upcoming months. Next slide. Change request 2744 will be updating the AR option drug panels based on updates made in the CLSI testing guidance. These updates will be effective with the AR events beginning with specimens collected in January 2022. You'll see these changes in the Antimicrobial Ingredients 2022 tab of the 10.1 IDM when it's shared later this year. Next slide. Change request 2745 has no CDA impact. This request will be updating the AR option phenotype definitions based on the changes made to the AR option drug panels as mentioned in previous slide. These updated phenotype definitions will affect the AR organism's line listing, frequency table, and rate table reports. Sorry. Next slide. Change request 2837 will require an update to the AR option pathogens for 2022. We will continue to use the AR option roll-up workbook for the 2022 AR option reporting. We will share the updated roll-up workbook later this year as well. Next slide. Change request 2680 has no CDA impact. Currently, the auto-generated MU3 report doesn't recognize when facilities indicate there are no AR events to report. This change request will update the logic for the MU3 monthly report to indicate AR event reporting is complete for the month when AR events are reported or if report no events is checked. Thank you. Next up is my colleague Wendy to discuss the AU and AR SDS updates.
Thanks, Melissa. I'm going to cover some AU and SDS stuff today. Some of it's relevant to vendors that haven't passed AU SDS, so please forgive me for those that have. Just want to make sure we provide folks information if you haven't passed yet. So this slide has a screenshot of our main AU SDS validation webpage. At the top, you'll notice an important announcement indicating that AU SDS validation is now required starting in 2021. This means vendors must pass AU SDS validation if they are creating AU CDA files for the reporting of January 2021 AU options data and beyond. AU CDA files that do not contain the required vendor OID and SDS validation ID will fail to import into NHSN. I'll go into a little bit more detail on those two items, vendor OID and SDS validation ID, in just a bit. So on this main AU SDS webpage, I'd like to point out a few more things. Towards the top right, there is the On This Page menu, which shows the other sections that are listed on this main AU SDS webpage. Below that, there is a See Also, which has quick links to the other three topic areas that I'll cover in just a bit. Another important item to note on this main webpage is that it has the downloadable AU synthetic data set with instructions in a zip file. And you'll notice that we just updated the data set this month with release 4.4. So I'll explain more about this new release on the next slide. So vendors that passed validation prior to April 12th of this year do not need to revalidate using 4.4. We did not add any new test cases or scenarios, nor did the database schema change. We fixed ward ID discrepancies between the ADT tables and medication administration table. Additionally, an enhancement was made to 3 drugs, penicillin V, diacloxacillin, and gentamicin, in that they are now assumed to be not electronically captured for all 4 routes of administration. Previously, vendors were to assume that penicillin V via the respiratory route and diacloxacillin via the respiratory and digestive routes were not electronically captured. This change means there is no need for 2 separate web service URLs based on the ability of the vendors to capture null values for some routes versus all routes of administration. For those vendors that were in the middle of using version 4.3, we can provide a temporary web service URL to continue your internal testing of 4.3 while you transition to using the 4.4 release. Just email us at nhsncda@cdc.gov if you need that temporary URL. We do plan to deprecate it on May 31st, though. It's important to note that even though the temporary 4.3 release URL will be available until May 31st, you must use the 4.4 release package for the official submission of your AU summary Excel file to the NHSN team for us to confirm you've passed AU SDS validation. The instructions document lists the appropriate web service URL to use for your internal testing of 4.4 release. It's the same URL that the NHSN team will use to confirm your file has passed validation. So just to reiterate, vendors that have not passed AU SDS yet must use the 4.4 release. So as mentioned on an earlier slide, I wanted to point out a couple of subpages. The Obtaining Vendor OID webpage is fairly self-explanatory. Please be sure you address the email to fintech but also copy the NHSN CDA at cdc.gov mailbox for a vendor OID request. FinTech cannot answer AU SDS specific questions as they are only assigning the vendor OID. If you have AU SDS questions, including next steps after obtaining a vendor OID, please separately email NHSN CDA at cdc.gov and not FinTech. However, before you do, please review the main webpage documentation and the AU SDS FAQs before asking about next steps, as the steps are outlined there. Also note that vendor OID is sometimes referred to as vendor application OID. Vendor OID is different and unique from facility OID. The vendor OID is assigned by FinTech and is unique for each vendor. This has raised questions, so let me state it another way as well. Vendor OID does not replace the facility OID. The NHSN application uses the facility OID to identify the facility in each CDA file so that the data can be uploaded into the appropriate NHSN facility. NHSN uses the vendor OID to track the SDS validation status of vendors and their software. Both OIDs are needed on the AU CDA files. Please continue to include facility OID as you have been doing in that section of the AU CDA. So jumping back to the email to FinTech, in response to your email requesting a vendor OID, FinTech will send you a vendor OID. I've noticed they turn it around fairly quickly, within a week or so, but you need to plan accordingly. You can always request a vendor OID while you are still working internally on setting up and testing AU SDS. So to reiterate, the vendor OID will be required in the author section of the AU CDA once a vendor passes AU SDS validation. Next slide, please. We currently have 23 AU SDS related FAQs. I highly encourage you to review these FAQs at the beginning of embarking on AU SDS validation and even throughout the process. Some things may not click until you're further along in the AU SDS validation process, but having the FAQs handy can help answer questions as they pop up. Next slide. The last AU SDS validation webpage I wanted to share is the vendors that have passed the AU SDS validation. This page allows current and future customers to be aware of vendor services and successes with respect to the NHSN AU option validation. So far, to date, we've had 19 vendors pass AU SDS validation. This page is a table, which includes the vendor name, including a hyperlink to the vendor's website that the vendor can optionally provide us, as well as the vendor software name, version of release, and the date the vendor passed validation. Table is organized alphabetically, so as new vendors pass AU SDS, they'll be inserted in alphabetically. I also wanted to point out the certification badge shown here above the table. We'll email you that badge once you successfully complete AU SDS validation, and you can feel free to include the badge on your website or vendor material once your software has been validated. Next slide. So to recap, this slide shows the main webpage and the 3 subpages that I just covered. You can link to them from the main AU SDS webpage or go directly to the topic of interest using the links on this slide. Next slide. This slide shows at a very high level the steps to take for completing AU SDS validation. You first should download the dataset in the accompanying instructions. I've included the link on this slide. So after thoroughly reading the instructions document, I would also recommend reviewing the FAQs like I mentioned previously to gain additional information or help answer some common questions that you might have. And I've included the link again here. In general, though, you should process the AU synthetic data set through your vendor system, just like you would with regular facility AU data. You should aggregate the data following the AUR module protocol for the AU option. However, the AU SDS validation, the output should be in Excel format so that we can confirm you've aggregated the AU data properly. Remember, AU SDS validation is intended for use in testing numerator and denominator data aggregation. It's not for testing conformance to CDA AU reporting. Next, you would upload that file to the web service that will validate your aggregated AU data against an answer key. This last step of your internal testing can be done as many times as needed to check your aggregated data against the answer key. Next slide. So once ready, send the NHSN team the AU summary Excel file in order to receive confirmation of successful AU SDS validation. In addition to the Excel file, and as part of the vendor registration process, please also include the following additional information as noted on this slide: vendor OID, vendor name, vendor software version, and at least one technical point of contact, the SDS Validation web service URL that you use for testing, and then optionally your vendor website. If any of the above information is missing apart from the optional vendor website, we will not process your request. After we receive your information, we are also following up via email asking if you'd like us to delay posting your vendor software information on the passing vendor's website. As some of you shared with us that you may want some time to incorporate the SDS validation ID into your software system and hence have us delay posting your vendor information to the public-facing website. So at this point, providing we've received the required information, we'll test your Excel file to confirm it passes validation. Next slide. So if the Excel file passes, an email will be sent containing the SDS validation ID to be added to your production AU CDA files. Additionally, the vendor name, software version will be published to our public-facing NHSN webpage to highlight successful AU SDS validation. If by chance that Excel file fails, an email will be sent indicating that the file failed, and it will list the errors received or a subset if there are a lot of errors. You can then resume testing internally, uploading your AU summary file to the NHSN web service tool as many times as is needed to not receive any more errors. And once ready, follow the same steps as outlined in the previous slide for submitting the AU summary file to us to confirm the file passes AU SDS. And our top question we get, one of the most frequently asked, is how often do I need to validate? And the AU SDS validation process is expected to be completed once per vendor per software version. So starting in 2021, all vendors creating AU CDA files will need to have successfully passed the initial AU SDS validation in order for their AU CDA files to either be manually uploaded or imported via direct into NHSN. No vendors grandfathered in. All clients using the same software version will have the exact same information in the author fields of the AU summary CDA. The NHSN team requires you to recomplete the AU SDS validation process only when major changes have been made to the AU option protocol. You should also complete the revalidation process when major changes are made to your software that understandably might affect the AU summary data aggregation. So next, I'd like to show the author section of the AU CDA and the expectations for including SDS vendor information. This slide shows an example of the XML coding of the author field. As highlighted here, the ID root must contain your vendor OID. And on this slide, highlighted, the extension must contain the SDS validation ID. So as a reminder, the SDS validation ID will be provided by us, the NHSN team, to you after confirmation of successful AU SDS validation. And highlighted on this slide, the vendor name, vendor software name, software version, and release are currently optional fields, but having this information will streamline the troubleshooting of issues. So those are the main points on AU SDS I wanted to point out. Next, I'd like to briefly mention AR SDS. We are close to having an AR SDS, AR synthetic data set ready to pilot and planned for the second half of 2021. As you can see from this timeline, we plan to have a validation requirement phase-in period in 2022 and require validation in 2023, like we did for the AU SDS, a phase-in period of a year and then the requirement. If you'd like to participate in the pilot phase of AR SDS, just please send us an email indicating your interest. All right, so in closing, just like to emphasize that should you have any questions about AU SDS validation or AR SDS validation, just to please email us at the CDA help desk box NHSN CDA at cdc.gov, and appreciate your time today. So I'll turn it over to Ahmed to cover NHSN vendor services.
Right. Thank you, Wendy. That was definitely a lot of information we just covered. My next few slides are meant to be more informative of other updates for NHSN. And I'll start by providing an update on additional functionality for vendor services. All right, so vendor services is currently available for vendors to request their facility's location data. Registration is required to use this function. Similar to how registration is completed for SDS, you'll need a vendor OID. However, no new hardware or software is required to use this service. All requests and responses are handled via direct automation. Facilities do have the option to opt out of using this service, and you can click on this link to find more information on how to sign up and use the vendor services location. We are currently planning to allow export of the monthly reporting plan, but this has not been finalized. All the features and functions that we want to include with this, we're still working to discuss this. So hopefully this will be a new feature available in the near future. Next slide. All right, next we'll cover some miscellaneous updates in NHSN. So future CDAs coming after 2021 and beyond. Number one will be for long-term care. We're currently working with LTC to create Lab ID and UTI. Once the implementation guide is published and becomes available, it will be shared with all the vendors and posted to the toolkit. We also do have plans to allow CDA for the outpatient procedure component. And the OPC will include an event and denominator for same-day outcome measures, a new SSI event, and a new denominator for procedure. Next slide. This slide covers a display of percentages of CDA imports versus manual entry and CSV imports, CSV for procedures. The year date range selected is to include completed quarterly CMS reporting. And you can take a note here of the increase in CDA submissions. Next slide. A quick update for direct CDA automation. We do apologize for the intermittent direct issues experienced last month. NHSN has added extra hardware to improve this service, along with working with our HIS to improve and streamline direct submissions. We have had traffic increase significantly. We are currently over 20 vendors submitting via direct, and the number of facilities sending via direct has increased to over 8,000 facilities. For those of you who are new or not using direct yet, it is a batch submission process with no immediate reply. We typically request to allow 24 hours for processing. And again, the turnaround time is based on the volume of messages in the queue. And if you are new to direct or want to learn more about direct, there is a direct toolkit on the NHSN website. Before you do start your process, we recommend that you schedule a call with us. We'll be happy to discuss the process for using direct, recommend best practices, and we'll have a developer and direct administrator join the call for a technical discussion. Next slide. CDA support is available on the NHSN website. The first link is to the main CDA submission support portal. Other important links provided on this slide are to the CDA toolkit and the guide to CDA versions. And just as a reminder, NHSN supports CDA versions that are valid for the past 2 years. Next slide. A few other helpful resources found using the following links. The first one is to NHSN newsletters. We also have release notes and communication updates. And then, next slide, please. Sorry. NHSN pre-production site, or NPPT, is available for all vendors. NPPT allows vendors to test their code in the environment prior to NHSN deploying it in production. To request a test site, please follow the instructions on this slide and send the completed forms to the CDA team. Next slide. When logging into NPPT, please read the important message at login. Currently, we are on the 9.5.3 version. We do try to keep this environment up to date when possible for upcoming releases. However, with the increased amount of releases on a monthly basis for the COVID module, NHSN is currently at the same version as production. We do plan on keeping this updated for our 10.0 and 10.1 releases. Next slide. All right, and as always, we welcome any feedback. If you are not on the CDA distribution email list, please let us know and we'll have your email list added to that list. The CDA team also does offer one-on-one quarterly meeting with vendors, and you can send an email to the CDA inbox if you haven't had a chance to schedule a call with us and would like to. Please include any topics of discussion so the correct SMEs and team members are on the call. Next slide. All right, and this concludes our April 2021 CDA presentation. We'll go ahead and stop the recording now. We do have a few minutes, so we'll allow some time for question and answers. You can put it in the chat box here. If not, if you'd like to just send us an email, please send it to the CDA inbox and we'll be happy to answer any questions.